Top Med Talk.
Well, hello and welcome to Top Med Talk. I'm Desiree Chappell, and I'm joined by my co-host in London, England, Monty Mythen. Hello, Monty.
Hey, Desiree, great to see you.
It is great to see you. So I would like to introduce our first guest from the AANA 2020 Virtual Annual Congress. He presented or will be presenting, he recorded and will be presenting on Tuesday, taking a closer look at sex, race, and social class disparities in pain. We have Edwin Aroke joining us today on Top Med Talk. Edwin.
Hey.
Hi. Thank you so much for joining us on Top Med Talk. Lovely picture behind you. Where are you coming to us from?
I am currently full-time faculty at the University of Alabama at Birmingham in the School of Nursing. I teach primarily in the nurse anesthesia program, but I equally teach across other DNP courses and other PhD students. My focus, being on tenure track, my focus is really research. My research primarily looks at the epigenetic basis of some of the racial disparities that we see in chronic pain. And equally, I am a CRNA by training, so I practice every weekend. Every week I go to the UAB main hospital where I still deliver anesthesia and manage that with some teaching.
Oh, fantastic. Well, you obviously are not from Birmingham. Your accent kind of gives it away. So tell us where you're originally from.
Yeah, so I was originally born in Cameroon, West Central Africa. I always say we decide whichever suits best, whether it's Central or West Africa. Uh-huh. And that was where I was born. Then came to Birmingham by way of Boston. I have been quite around, which is one of the things I say with my accent. Every city I stop at or state, I pick up their accent and modify it to suit mine. So I came from Boston by way of North Carolina, where I did my nurse anesthesia training at Duke, and then practiced at UMass Medical Center for about 5 years or more, and then came down to Alabama.
Oh, fantastic. Well, you're in the presence of another Dukey. Monty spent some time there at Duke.
Yeah, I'm an alumnus. I was visiting there in 95, 96 sort of window and joined faculty. And I'm back there as an adjunct professor. So do you support the Blue Devils or?
The Blue Devils, yeah.
Do you? Or is that just what you have to say when you're? Because you've been a lot of places. You've got a lot of choices now. So.
No, once a Duke, you always won.
Yeah, exactly. They got you.
Good answer. Well, Edwin, we're coming to our listeners from the AANA Annual Congress. So it's all virtual. We're all virtual. But for a lot of listeners out there, they may not understand what the AANA is and what being a CRNA is. And you know, most of our listeners know Monty is an anesthesiologist or a anesthetist and critical care doc in England. And I am a CRNA myself, a certified registered nurse anesthetist. But for our listeners, can you tell us a little bit more about what the AANA is?
So the AANA is the Professional Association of Nurse Anesthetists in the United States. So as of last count, we have somewhere around 55,000 nurse anesthetists in the United States, and the AANA is our mother association. Within that, I specifically serve within the Diversity and Inclusion Committee within the AANA. So that is kind of where we sit, and hopefully would have been exciting for us to all be in San Diego and be screaming up and down, meeting everybody. It's always so fun to be there for the annual Congress. Tell
us a little bit about this presentation that you did for the AANA.
So one of my main reasons for even choosing this topic was, I came to the realization that, when we go through training, there's a very big emphasis on the biomedical model, right? And I am guilty of that. Like I just mentioned a few minutes ago, my research is in epigenetics, still going back to that biomedical model and really emphasizing like the pain pathways, the neurons and the synapses and the fibers. But when you really come to think about it, pain is really an experience to the patient. And so there is a whole lot more to it than just the neurons. We all may biologically be very similar or the same, but we all come to experience pain very differently. And now over the years, we've come to realize that, while pain is something that is universal for all humans, specific populations, i.e. maybe when you look at sex or when you look at ethnic groups or racial differences, or when you look at socioeconomic status, you realize that, it's not all the same. How do you explain the fact that two patients undergo surgery, one recovers and goes back to baseline and is living their life, while the other person develops persistent pain? So that is really what intrigued me. And I felt like, for the CRNA audience, it would be good for us to take a closer look at that and say, what is it that is driving this? Are we really considering all the factors, or are we too biomedically focused? Should we really be taking a closer look? Okay, what about the psychological factors? What about sociocultural factors? What about the socioeconomic status? What about the patient's own expectations of how much pain they can tolerate? So those are things that I wanted to really dive into. And specifically, I think in the lecture, I introduced the notion of the biopsychosocial model, which is really encapsulating all of this. Really looking at not just the biological, but the psychological, the social, and the cultural aspects of pain.
So Edwin, if we can just remind ourselves, for me really, of some of the basic terminology. We all we understand nociception. In other words, we've got this sort of neural infrastructure that senses potentially harmful signals, and it triggers certain nerve fibers, and it goes to, let's call them pain centers, for example. That is triggering to create a nervous impulse. But as you've been referring to, pain is what we make of that, the sensation that we feel, how we interpret that stimulus. Therefore, the people talking about different pain thresholds, triggering off the fibers, the thresholds are pretty much, let's call them all the same for argument's sake. But what we do with that signal varies quite a lot. Is that a reasonable executive summary? That's the distinguishing the pain bit. Yeah.
That is very accurate. And that is one of the reasons why not very long ago, the International Association for the Study of Pain came up with an even revised definition of pain.
Okay.
That way, capturing that emotional aspect. You now acknowledge that pain. So for instance, an unconscious patient, right, like for us CRNAs and anesthesia providers, when the patient is unconscious, well, they still perceive pain. We see changes in the vital signs telling us that there is pain transmission and pain perception going on. So that emotional aspect of it. So just because somebody could not express pain, right, doesn't mean that they cannot feel pain. And that revised definition really captures that well.
And one more piece of revision, because I think it all potentially does come into it, even though it's going back to some of the basic science. The epigenetics, I think we all understand genetics. In other words, the genetic code that fingerprints what we become. But the epi bit, what's the epi bit in the epigenetics?
So the epi base epi comes from the word beyond, right? And the idea really being that, for instance, if you have two identical twins at birth, okay, they have an identical genome. So their genetic is the same. But now as they go through life, environmental factors now influence which of those genes are turned on or turned off. And that is really the basis of epigenetics, where we want to really see, your environmental, and when we talk of environment, it's really not just external. It could be internal environment as well. So for instance, if you have an identical twin and one of them undergoes chemotherapy, for instance, right? We know that phenotypically, they will lose their hair, their physical appearance is going to change. That is a very classic example of an epigenetic change. And similarly, we call it maybe like patients who are alcoholics. We all have seen that in the OR where somebody who has drunk for quite a while may appear in terms of their phenotype, how they look, older than they are. That is an epigenetic change because that environmental exposure has regulated which gene is turned on and which gene is actually turned off.
And it's because, if I'm right, we don't use that much of our total genetic code, so there's a lot to spare.
That is correct.
And as I've understood, the thing that's happened more recently in the science is how quickly you can turn bits on and turn bits off with exercise, diet, alcohol, drugs, emotions. And that's with things like methylation, for example, of the various different bits of the genetic code. And I've even seen some cool bits of science where someone's, being pushed hard in the gym, and you can almost see with certain techniques the code being switched on and switched off. Very, very challenging stuff.
I mean, definitely, methylation, which you mentioned, is one of the most studied epigenetic change. And there is a group, Susan Dorsey out of the University of Maryland, they have looked at exercise and its effect on chronic lower back pain and saying whether does exercise induce epigenetic changes as one of the beneficiaries, kind of like the underlying mechanism by which exercise helps with chronic lower back pain. So there is definitely, and that to me was one of my draws into epigenetics, the fact that you can induce, the environment can induce these changes, but they are reversible. You know, even though it can be passed on from generation to generation, it's actually reversible. It's not static, similar to like a genome. With genome, when I did my first study, it was on pharmacogenetics. And I always say, okay, if I tell you you have this gene, so what can you really do about it? You know, there's very limited, other than me telling you, well, avoid this drug or avoid that one. But with the epigenetics, I feel like we can start working on some of those. Okay, how can we reverse some of these environmentally induced changes?
So another way of looking at it is there's always hope. You can't just let your cards you were dealt, get over it. You can, you know, you can do something about it.
I'm going to tell my mom that whenever she says, oh, it's all no, well, Edwin, talk to us a little bit more. I mean, this is absolutely fascinating subject. And, you know, you think about your patients that you have coming out, you think you hit the mark on their pain, and, you know, you did the same thing you did for the last one, and it worked beautifully. And then, you know, this is an intra-op, of course, and then post-op, they come out and you're like, what just happened? Like, everything looked great, and now they're saying they have a pain score of 10. To me, it's just a difference in patient. You know, I mean, it doesn't necessarily mean, you know, I'm not looking at their socioeconomic class or race or anything like that. It's just a difference in patients. But you're saying that it can dive a little bit deeper. Is that correct?
Yes. And I think one thing that we as providers, so that is a problem that you can look at from different perspectives. So you have patient factors, then we have our own judgment as providers, and we have all the environmental stuff, right? So if you look at it from the patient's perspective, one fundamental thing that may be driving that may just be the fact that that patient, what is their prior exposure to maybe the opioids you are using, right? What is their experience, or what are their expectations of that pain control? And I always give the example of somebody living in cold weather versus warm weather. So if I ask somebody who has never been out of Birmingham, Alabama, how cold it is, their reference may be a freezer, right? Because they haven't experienced the cold vortex of Chicago. You know, so when they are telling you it's 5 out of 10, that 5 out of 10 may not necessarily be your 5 out of 10 or or Monty's 5 out of 10. So initially, I think that is really where providers have to start by establishing that baseline for the patient. What is a reasonable pain threshold? What is a reasonable pain goal as we go to treat your pain? What should be our reasonable expectation? Are we striving for a 0 out of 10, or are we striving for a 5 out of 10? Once you establish that, then you can now start looking at, okay, what are other issues that the patient has? Do they have any comorbid factors? Do they have chronic pain as a baseline? Are they already exposed to opioids? Are they on other drugs which can interact with the medications we are going to administer? But now going back further into really the meat of my talk, it's really looking at, well, now once we feel that once we have accounted for those things, then we realize that there are some general trends within different populations where we see that, hey, women overall, females tend to report more pain than males. And that is something that we really don't know. One, at the individual level, again, could it just be because of the fluctuations of hormones? We have seen studies showing that, hey, when you measure pain, depending on what phase in the menstrual cycle the female is in, you have different sensitivity to pain, especially in experimentally induced pain. And we equally know that most of these pain differences that we see, once women menopause, they start leveling off. So it means that the hormones are playing a role, but we don't quite know specifically yet. We know that on the male side, testosterone plays a big role in, cognition and how they behave, and just our, societal perception of manliness, right? So what does that really mean to the patient? Does that mean that if you ask a male patient how much pain they are in, they are more likely to not even tell you the truth because they think it's unmanly to be a wimpy, or they're going to be forthright and tell you.
Yeah.
So those are some of the sex differences that you begin to tease out, again, at the patient level.
Yeah. I would have said women have a higher pain tolerance than men just because of the whole having babies thing. But that would, that's...
That has been something that has been investigated quite a bit. And I think that was my biased view too. I always felt like women could tolerate pain more than men. Yeah. But I think what happens is when you look at prevalence, for instance, there you see that across multiple chronic pain conditions, women tend to report higher prevalence of this. Mm-hmm. And I think that is where the difference comes in. And again, it goes back to, is it a biological, i.e. hormonal, inflammatory cytokines and things like that? Or is it just the fact that women just take better care of themselves, right? I mean, I would say in my household, I go to the hospital when my wife tells me, you have to go. It's not because I necessarily think I'm supposed to go, but she says, hey, you have to go. I'm like, okay, I will. Yeah.
In some parts of the UK, men go to the hospital when the ambulance arrives.
Yeah, exactly. Yeah. Well, it's really interesting to think about because, you can kind of explain, it's almost explaining away, this difference in gender because of hormones or whatever else. But what I found especially interesting was the fact that you brought up race and social class, like economic, socioeconomic differences. Tell us a little bit more about that.
Yeah. So race and social class, especially here in the US, are things which it's very difficult to separate, right? I mean, actually, some investigators have said you cannot truly understand race without considering social class. Mm-hmm. And one best way to really understand the race difference and the effect of race on pain is really informed by this idea of the minority stress theory. And basically where that comes from is the idea that for racial minorities, especially Blacks, they are exposed to chronic stress, the stress of daily, racism, where, maybe going to the store and being looked differently. Of late in the news, we all have heard about the encounters with the police, having the talk with your son and things like that. That chronic stress, right, causes dysregulation in the hypothalamic pituitary axis. So basically, it's kind of like living at a perpetual state of chronic stress. Well, naturally, if you are exposed to high levels of cortisol over time, the body is going to adapt. And one of the current hypotheses is that induces inflammatory changes and dysregulation in the autonomic nervous system, which may now lead now to a heightened state. So kind of like a perpetual state of alertness. And that may be what is driving some of the racial differences that we see in chronic pain. Again, that is one theory. On the other hand, you may equally be, when you think of racial differences, and you think about the patient-provider encounter, historically, you've had situations where Blacks, for instance, may not necessarily feel that the provider trusts them. So there is that possibility of that imbalance. One, they do not trust each other. So how much of the pain are they reporting? Do they wait until the pain is so bad, then show up as i.e. now when we are measuring it, it's more severe. But unfortunately, at the later stage, we have seen that as a problem across multiple chronic conditions, including even cancer, where racial minorities will show up when it's really bad, not when something could have been done about it. So there is that idea of lack of trust within the system, where they do not even trust the system. And it becomes a big problem for us anesthesia providers. When they show up to the OR, you are doing your best. You want to take care of them. But now if the patient lying there is not trusting you, we know that rapport is very critical in outcomes. Mm-hmm. And it's not just in pain outcomes, but every eye care outcome. You need the patient to trust that you will have their best interest at heart. And equally, you have to equally be going into it feeling like the patient trusts you. So if that trust is broken because of historical factors, that is one of the main drivers.
So Edwin, on the chronic stress theory, and maybe it's more than a theory, which is the purpose of my question, that relates to the grumbling stress component of it that relates to race. Are there epidemiological signals to suggest the fact that this is less of a problem in more racially tolerant counties, regions, parts of the country, wherever we are? I take London as an example. We think we're much more racially integrated and that there may be less chronic stress levels in London. I might be right, I might be wrong. There are certainly other parts of the countries where you get the impression that you might be part of everyday life being stressed about having a different coloured skin. Are there studies that support that hypothesis?
Yes, and that is where the whole idea of you cannot really study race without consideration of somebody's socioeconomic status comes from. The idea that somebody who lives in a more violent neighborhood, right, who is more exposed to daily violence, they tend to report higher levels of pain.
Yes,
and that correlates with higher levels of daily stress. Yeah, so that is definitely a factor. But one thing that, as we think about our current environment, COVID-19 has kind of thrown a wrench into everything we thought we knew, right? Yeah. Because that is something that I've been thinking quite a bit about too, because some of the studies coming out seem to be saying that, I specifically thinking about the study out of MIT, where they were looking at racial differences and disparities in COVID-19. And they said, well, race alone is just an independent predictor by itself. So even when you account for socioeconomic status, race stood it by itself. So that to me really got my attention, because I was like, well, I guess if we are saying, let's dissociate socioeconomic status and just look at race, and it remains a predictor, means there must be something else. And it goes back to where I said my research really grounds itself. Could it be that some of these changes have already happened and are now already being passed on from generation to generation, such that we now have to basically do interventions, to reverse those changes, i.e. some of the epigenetic changes that I was saying. Because we see that, go ahead.
I was going to say, Edwin, my understanding of some of the early work with regards to how susceptible was to COVID-19, it actually looked as though some of that was actually genetic as opposed to the compounding issues of epigenetic. The susceptibility to the access of COVID-19 via certain receptors is racially different at a genetic level, which is challenging as well. So very complicated.
Yeah. So I think that is why I say COVID has come to really, it's thrown a wrench into everything we thought we knew. And I think as investigators, we all are now taking a step back to say, okay, what do we know? What do we truly not know? And how do we go back and really rethink about some of the hypotheses which have been supporting our science and the way science is driven?
Yeah, absolutely.
And the two overlap, Desiree, in a very, very tangible way for people who can see it. It would appear to be that if you're white and wealthy, you're relatively protected. But if you're white, wealthy, self-abusive, obese and inactive, then the epigenetic component has negated much of the genetic advantage.
Yeah.
And we see that in some very famous people just down the road from where I appear to be sitting in London at the moment. We're a classical example of that. They had all the opportunity to not suffer from COVID-19, but they overwhelmed it with epigenetic components.
I wonder, though, as CRNAs, as anesthesia providers, how do we use this information? How is this going to change my practice tomorrow?
How is this going to change your practice tomorrow? I think one thing is, which I didn't mention, is the role of the provider, right? So what is our own contribution to this, right? Because we cannot be the drivers of the ship and all of this is happening within us. And we say, well, it's only the passengers. No, not quite. we must have some level of contribution to whatever is going on. I think you've probably heard this thrown out quite a bit, implicit bias and all of that. I think as providers, that is really where we have to own it and say, well, implicit bias is something that all of us have. Okay, it's part of human nature. I mean, if you just think about when you are stressed out, right, and you are under intense pressure, you are more likely to default to innate actions, right? You act without even thinking. You start doing things that you've done most routinely, which is why for us anesthesia providers, we say, for every skill we want to do it so many times that you can do it in your sleep, right?
Yeah.
Well, not like, so that is really what implicit bias kind of is. Those are the unconscious things that have been ingrained in our mind. So now when we are under intense stress, right? And if somebody tells you that, oh, they have a pain of 8 out of 10, unconsciously, you may be saying, is this truly an 8? Yeah. I don't really think about it.
They don't look like they're an 8. They look like they're a 5.
They have an 8. Yeah. And what are you going to treat? You will treat your interpretation of the pain that they are telling you. You will not treat necessarily what they are telling you, right? Yeah. And that has been brought up in this lens theory, which is basically to treat pain, we take cues, we look at the heart rate, we look at the respiratory rate, look at their demeanor, and then they give you a number. Where that number is only interpreted within those other cues. And that your outcome and how your intervention is going to now be based on that composite score, your ungenerated composite score. That is one thing that we all can do. Start saying, hey, if a patient says it's 8, before I think it's not an 8, let me really take a step back. Why do I truly think it's not an 8? What is informing that decision?
Because the risk there is of your conscious bias or unconscious bias mixed in with that. But so to try and make that more objective, we've done a few interviews over the last year about nociceptive monitoring, the idea of using monitoring techniques that look at physiological variables to give you a number that suggests the fact that you are experiencing pain, which adds another complexity to it. Machine says no, you say yes. Some of these are approved in Europe now. I don't think any are approved by the FDA in the USA. So now you can say, well, you can tell me it hurts as much as you want, but the computer says no. What are we going to do with that?
That'll be interesting.
Yeah. I'm sorry. Computer says no.
Yeah. So I think that is really where things are going. And kind of in line with that, Monty, is equally the whole notion of preoperative quantitative sensory testing, right? Where we want to be able to preoperatively test how sensitive you are to pain so that we can predict. Well, how much of that do we really, do we buy into? As providers, we want the latest and the greatest knowledge out there, the best evidence to take care of our patient.
One of the things you said, having the sensitivity screening kind of before, but are there any validated tools that kind of look at some of the points that may allude to the fact that the patient may have increased pain, post-operatively? So you said, if they've had prior exposure to opioids, all these different things. Are there any validated screening tools that we could perhaps use to inform the way that we treat our patients' pain?
There are several tools which look at general pain. Very few have really focused on preoperative assessment as a predictor of post-op pain. And the real reason being, one, during the preoperative phase, acute pain is something that is very different, both at the physiologic and control level from chronic pain, right? So as much as we want to be able to predict acute pain, it is innately challenging. The closest I know of are studies looking at using quantitative sensory testing. The idea being you want to induce a stimuli that you can control for. Because again, going back to tools, one of the biggest critique of measurement tools has been the fact that they're all subjective. So you are using a subjective tool to, predict an objective outcome. That for scientists, somebody who is a pure, believer in objective science will tell you, well, that is really not true. You should use objective measures to predict objective outcomes. You can't use a subjective measure to predict an objective outcome. So for now, the main answer is not that I know of. I don't really know of any good measure at this point that we can use to predict. But we know, like I said, you've concurred a few minutes ago, there are a few things that as providers, we have to always be alert for. Does the patient have any history of prior exposure to opioids? Does the patient has underlying chronic pain? Okay, does the patient have any other comorbidity? So for instance, mood disorders, anxiety, depression, right? Those are things which have been shown to be all catastrophizing, Right? Those are things which have been shown to be strong predictors of more severe and disabling pain.
And Edwin, is there any mileage at all in asking somebody where they think their pain threshold is? I know that's a very unscientific thing to say, but I mean, if I was asked, I might be wrong. I would say that my pain threshold is, moderate to high, because I played a lot of physical contact sports and maybe preconditioned myself to the joy of pain. But or maybe I didn't. But is there any mileage? And other people, some of my relatives would tell me that they're have very, very low pain thresholds. In other words, any little thing hurts a lot. Is that a crazy thing to ask?
No, I think it's a valid assessment. And I would say you piggyback that, especially if you are talking to a patient pre-op, what level of pain is acceptable for you?
Oh, that's good.
If you add those two, that gives you a pretty good idea. Because you may equally appreciate this more, because I remember when I used to do OB anesthesia, you will walk into the room where the nurse is telling the patient, once they do place your epidural, you will feel no pain. I'll say, no. That is not the idea. All right. The idea isn't that you will not feel pain, is that we're going to make it bearable. We're going to make it so that you can still tolerate this. What level of pain is acceptable?
Yeah. And you wait till they're 13 or 14, they can always hurt you.
Yeah,
that's true. The kiddos do that. Well, Edwin, this conversation is fantastic. Thank you so much for shedding light onto this topic that, honestly, I've probably never thought of, and many of us as anesthesia providers probably don't think of on a daily basis, taking care of patients, case after case after case. So it gives us food for thought, for sure. Thank you for all the amazing work that you're doing, teaching our future generations of nurses and CRNAs. That's fantastic. Thank you for all that work.
No, thank you for having me.
Yeah, absolutely.
This is a topic I'm very passionate about, and it's exciting.
Yeah, you can tell. I love it. It's whenever that passion is palpable, it's great.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.